Good morning, friends. Today we are going to talk about unusual fungal infection, almost always a primary immunodeficiency disorder. Well, this is an interesting topic which we will talk about, and I cannot but begin by thanking my mentor, Dr. Zeenat Karimboy, who, at the age of 80, thought that she has already established the Department of Pediatric Hematology Oncology, and now she should go ahead and establish the Department of Immunology. And it is only because of her drive that I am doing immunology and standing and talking in front of you. This is the Mumbai Immunology Group, and we are having more and more youngsters who are getting interested, and it is a very heartening time for all of us. Now, we all know that Mumbai is the fungus capital of India, and there is a valid reason for that. We have too much of constructional activity, too much of infrastructural project going on, extremely high incidence of diabetes mellitus, a large migrant population with a large population of retroviral disease. In certain communities, we have in who have inbred over centuries, married within their own caste and community. So we have a genetic restricted pool because of which we know that inborn errors of immunity are much more common in our country. In India, the monsoon plays a very important role, the weather plays a very important role. There is extremely high humidity, and fungal infections are extremely common also because we have doctors who believe in aggressive, irrational therapeutics. So fungal infection may be much more common in India than what we think. And challenge in India is that we have all types of fungi in our country. We are also endemic for Histoplasma capsulatum. We have problems of drug resistance because drugs are used too frequently. So please remember, unusual fungal infection almost always a PID. PID can also present with unusual fungal infection. So we just analyzed our data at the Department of Immunology at by J. Baiwadia Hospital for Children, and it's very interesting that we had 125 patients who had fungal infection as a presenting manifestation of their PID, or they developed fungal infection over a period of time. 95 of them were Candida infection, which is the commonest fungus we come across. Aspergillus was seen in 29 of the 125 patients. We had skin trichophyton infection in 5, mucor in 2, histoplasma in 1, coccidioidomycosis in 1, basidiobulus fungus in one of our patients of chronic granular disease and penicilliosis. So we have a large variety of fungus, but the commonest fungus is going to be Candida and Aspergillosis. Now this is the distribution of PID which in whom fungal infection are commonly seen. So I guess the commonest infection which you're going to see is severe combined immune deficiency, where the fungal infection is going to be most common. This is T cell defect, and in patients with T cell defect, we all know that we would invariably have and mucocutaneous candidiasis is a common presenting, and then we could have somebody who coming to with invasive fungal infection. Chronic granulomatous disease was seen in 22% of them. And remember that a large number of these patients get aspergillosis, but sometimes they get penicilliosis, basidiobulus, and other things. Then patients of MSMD or Mendelian susceptible mycobacterial disease, especially IL-12 receptor beta 1 defect, are also prone to Candida infection. The gain of function STAT1 is another common cause for fungal infection, especially mucocutaneous candidiasis. Fungal infection is very rarely seen in patients of antibody deficiency, but we could see it in some patients of CVID where there is combined both B and T cell defect. So you have a huge variety in which primary immune deficiency patient and fungal infections are associated. And this is a cartoon which will show you that in which immune deficiency you see what type of fungal infection. So as I've shown you over here, CGD, I've already mentioned to you that they are prone to getting aspergillosis. but they can develop penicilliosis, Candida parasilosis, glabrata. We had one patient with Candida guillermondi. In patients of MSMD, because they cannot handle intracellular organism, they are more prone to histoplasma infection. They are more prone to coccidiomycosis. Very rarely they develop aspergillosis, but Candida is one which is very common, especially in IL-12 receptor beta-1 defect, because there is a defect in Th17 pathway. In STAT1 gain of function defect, the commonest fungus is still Candida because it is the commonest cause of chronic mucocutaneous candidiasis, but you can see cutaneous infection with trichophyton, and you can see infections with aspergillosis also sometimes. Patients of SCID very often have aspergillosis, candidiasis, they are prone to all types of fungal infection. Patients of Docket deficiency, we have a large number of Docket patients who develop nocardia or they develop candida infection and aspergillus sometimes, though they are very commonly prone to viral infection, they can also develop fungal infection, and that could be a presenting manifestation in some of the patients. So this is just to show you an unusual fungus as an unusual site. This is a child who came to us for pneumonia, was receiving IV antibiotics, and he developed this necrotic ulcer at the IV injection site, which was biopsied, and on biopsy we found this Basidiobulus fungus, and we asked why should there be an unusual fungus at an unusual site, and that's why we suspected an immune deficiency and did a workup, and he turned out to be a case of chronic granulomatous disease. Sometimes you can have a usual fungus at a usual site, but for unusual severity and for unusual duration of time. So this is an infant in which Candida is much more common. This infant has, you can see, a very severe form of candidiasis, and this is a persistent candidiasis, which made us suspect that he definitely has an immune deficiency, and it could be a SCID. But remember, this fits into a chronic mucocutaneous candidiasis, and most patients with chronic mucocutaneous candidiasis have defect in their Th17 pathway. This is an unusual fungus in an unusual location, in an unusual situation. This is the story of a boy who is 18 years old who first presented with an ear infection which on debridement grew penicilliosis. Subsequently, after about 8 years, he again developed an sternal mass which turned out to be penicilliosis. In between, he developed ataxia and on investigation was found to have a cerebellar abscess and a frontal abscess, as you can see over here, and this was biopsied and it turned out to be aspergillosis. Now, one dictum which we follow is that if you ever see an aspergillosis in a non-neutropenic setting, you must rule out a chronic granulomatous disease, and that is what we suspected. Besides this fungal infection, he also had an atypical mycobacterial infection. So the organism here was an important clue to suspect chronic granulomatous disease, and this patient turned out to be a case of chronic granulomatous disease. Peculiarly, I'll come to that later. Now, if you see an Aspergillus nidulans in humans, it is always in the setting of chronic granulomatous disease. Normally, we never get infection with Aspergillus nidulans. It only happens if you have chronic granulomatous disease. So this is an unusual fungus in an unusual host. Now, this is the story of a boy who has a common problem, diabetes. But diabetes is not common in children at this age. He has other autoimmunity, steroids, ITP, he is treated with steroids. He has diabetes, he is prone to infection with fulminant varicella infection. And he has a fungal infection which he is finding it very difficult to clear. Now, because of his multiple autoimmunity, fungal infection, he also had celiac disease, a fulminant varicella zoster infection. We picked up and investigated him and picked up a diagnosis of LRBA deficiency. So this is a classical situation of unusual fungi, unusual risk factor with an unusual diagnosis. Now this is the case which has been shared with me by Dr. Koneti Rao from NIH, and this is the interesting story of a girl who developed a severe subcutaneous pheohyphomycosis. This patient was first seen at the age of 4 years at NIH, and this was the presentation. She was treated with antifungal and she responded very well, but she stopped therapy. And then when she presented, you can see the kind of destruction this disorder has caused. And anybody would suspect an underlying primary immune deficiency. She was worked up at NIH in US, and there she turned out to be a case of CAR9 deficiency. And you can see the devastation that this CAR9 deficiency can cause, and it has structurally altered the anatomy of her face, her eyeballs, and it is really, really disheartening to see such kind of presentation in this time and era. Now, this is the boy who was referred to a cancer hospital thinking that this is a tumor. He had a nasal mass. This nasal mass had eroded into the orbital plate and caused proptosis. It had eroded on the base of the skull and it was reaching the dura mater, and so he was operated upon. On histology, to everybody's surprise, it showed hyphae consistent with fungal infection. Once again, he also had mediastinal mass, as you can see, which was biopsied thinking this could be a non-Hodgkin lymphoma or a Hodgkin disease. And to everybody's surprise, the biopsy also showed hyphae consistent with fungal infection. He was treated successfully with voriconazole. Now, as we have talked before, aspergillosis in a non-neutropenic setting will always mean CGD unless proved otherwise. So we were very excited that this could be a CGD, but when we did the workup, the NBT and the DHR by flow was negative. That means that he has got something which is making him prone to an aspergillus infection. And I think this is something which tells us he needs a whole genome sequencing. We need to find out a mutation which is probably making him susceptible to fungal infection. We need to appreciate at this point that there are still many Mendelian diseases yet to be discovered, and this is a type of patient where we need to investigate further to work out what kind of underlying immune deficiency you must be having. So friends, all of you have an opportunity to discover a disease and put your name to it. Now this is the slide which shows us that fungal pathogens are common in primary immune deficiency disorder. So we'll talk about the fungi and in which primary immune deficiency they are more common. Now, if you see chronic mucocutaneous candidiasis, then you have a huge list of primary immune deficiencies which make you prone to candida. Please remember, chronic mucocutaneous candidiasis is generally always because of a defect in adaptive immune system or the T cell defect, while invasive fungal infection is invariably because of defect in phagocytes. It's a phagocytic defect or defect in innate immunity. Patients who have histoplasmosis or susceptible to histoplasmosis, particularly because of defect in IL-12/23 interferon gamma loop, besides SCID and CVID. Patients of aspergillosis are CGD patients are particularly prone to aspergillosis. Hyper IgG, STAT3 are also particularly prone to aspergillosis. This is so also are patients of severe combined immune deficiency. This is something which we need to keep in mind. Now this is an important cartoon which tells us in which primary immune deficiency, which infections are more common. So if you notice, most B cell defect, unless they have a combined T cell defect or treated with steroid, don't get any fungal infection. Patients of phagocytic defects are particularly prone to invasive fungal infection with candida and aspergillosis, while patients of T cell defect are particularly prone to mucocutaneous candidiasis. If they get an invasive fungal infection, then it is going to be a pneumocystis jirovecii, and that's the only infection they are more prone to besides Histoplasma capsulatum. The scope of infections and PID is increasing, and this is to show you that patients who have CMC, once again to reiterate, have a defect in Th17 pathway, while patients of IL-12/20 interferon gamma loop defect have susceptibility to intracellular organisms. That means they are susceptible to intracellular fungi like Histoplasma capsulatum. That is something which we need to understand. Now this is we talk a little bit about how the immune system handles fungus, And we must remember that the first line of defense for any fungal infection is mucosal barrier or skin barrier, and you have certain antimicrobial peptides like beta defensin which help you fight and prevent colonization and prevent infection with uh, various fungi. The second line of defense, of course, is an interplay between adaptive and innate immune system, which we'll see shortly. Now, for control of intracellular bacteria and intracellular fungi, you need the Th1 pathway. For control of parasites and extracellular bacteria, we need Th2 pathways. While for control of extracellular bacteria and fungi, we need the Th17 pathway with a signature cytokine which is important for mobilizing the neutrophil to the site of inflammation. This is a dendritic cell or a phagocytic cell or a macrophage, and here we can see on the surface we have specialized receptors to recognize the pathogen associated molecular pattern expressed by various fungi. So we have C-type lectin receptor which can recognize the beta-1,3 glucan or N-link mannans and chitins which are present on the fungal cell wall, and we have various other receptors like the DC sign, dectin-1, dectin-2, Minkel, which play an important role for recognizing the fungi. Some toll-like receptors, like toll-like receptor 2 and 4, also recognize certain pathogen-associated molecular pattern present on the fungi. And thus, when this thing get activated, when this receptor get activated, they internalize the fungi and they activate the inflammatory pathway. And we will talk very quickly about this pathway. So fungal recognition is because of the pathogen-associated molecular pattern like beta-1,3 glucan or galactomannan or mannans. Now what happens, how of the signaling, what kind of signaling pathway is seen downstream of dectin-1 and dectin-2 receptor? So once the fungi is recognized, it is phagocytosed. Upon phagocytosis, there is formation of a phagosome. At this phagosome, if there is an activation of the respiratory birth NADPH, this fungi will become killed instantaneously. If they are not killed, they remain in the phagosome and they get in turn uh, convert from their this being a dimorphic fungi will convert from the cystic form to hyphae form. And when a hyphae escapes from this phagocyte into the cytoplasm, it activates the NLRP3 inflammasome. Now, activation of this NLRP3 inflammasome is extremely important. This would result in conversion of pro-IL-1 beta to IL-1 beta, the active cytokine, because this cytokine is necessary for upregulation of co-stimulatory molecule and maturation of the dendritic cell into a full effector antigen presenting cell. The subsequent downstream activation requires CARD9, BCL10 and MALT1, which will in turn activate the NF-kappa B, the MAP kinase and the JNK pathway. All three of them will work together to increase secretion of inflammatory cytokines like IL-6, which is very, very important, IL-2, TNF-alpha and IL-23. Plus, this cytokines or this transcription factor also increases the expression of co-stimulatory molecule which is necessary for T cell activation. Now, this cytokines, especially IL-6, play a very important role in priming of naive T cell for proliferation and differentiation into Th17 pathway, which is important for controlling the fungi. Now this is just to show you in a cartoon form the mucosal surface. Now we all know that we have the yeast form of Candida which is commensal, but due to environmental factors, or say if patient is diabetic, or if the patient is receiving immunosuppressive therapy or antibiotic therapy, there is a pressure for changing of cystic form to an invasive hyphal form or the yeast form to invasive hyphal form. The invasive hyphal form with a pseudo-hyphae expressing the pathogenesis molecular pattern can be recognized by the epithelial, but they have higher invasiveness. Once they invade inside, then we have the macrophage which takes it up with the help of dectin-1 and dectin-2 receptor. There is a formation of phagosome. If there is activation of the NADPH oxidase, it will result in the formation of superoxide and hypochlorite solution of phagosome and killing of the yeast form of fungi. If this phagosome, the yeast gets converted into the hyphae form, this hyphae can escape from the phagosome and activate the inflammasome, which in turn will result in formation of IL-1 beta, which is very important for priming this cell, the antigen presenting cell, and for its maturation, as we have talked about. Now, what happens? How does the development and effective function of Th17 take place? So once you have an antigen presenting cell which is now fully mature and it is presenting the various antigen of the fungi on its MHC class 2 and class 1 molecule, and there is expression of co-stimulant molecule, the naive T cell in under effect of IL-1/6, and this activation gets differentiated into Th17 cell. The most important cytokine is, the most important transcription factor is the STAT3. Now IL-6 activates the STAT3. Now this STAT3, if it is mutated and there is a loss of function, results in what is known as results in hyper IgE syndrome or Job syndrome as we know it. This STAT3 will in turn bind the DNA elements and cause expression of ROR gamma T and ROR alpha. Now these are the signature Th17 cytokine. Now this will in turn drive this naive T cell towards proliferation and towards Th17 pathway differentiation. Now this Th17 cell produces its signature cytokine, which is IL-17A, IL-17F and IL-22. Now this cytokine will induce beta defenses in the epithelial cells. It will cause its production and activation. It will also cause production of GCSF. Now GCSF will in turn enhance granulopoiesis, and there will be expression of the CXCL18 or CXCL8 chemokine, which is a neutrophil chemokine and result in recruitment of neutrophils coming to the site of inflammation. Now this Th17 cell also expresses CCR4 and CCR5 chemokine, which will help in the migration of Th17 cell into the inflamed tissue. It will in turn also produce other inflammatory cytokines like TNF-alpha, IL-26 and IL-21, but it will also produce IL-6. Now IL-6 is important to recruit more naive cells to differentiate into Th17 cells, and this in turn keep augmenting its own loop. Now this is what is happening at the epithelial cell level. The Th17 is activating with the help of IL-22. It binds the IL-22 receptor and IL-17 binding the IL-17 receptor, which will once again through STAT3. So STAT3 also plays a very important in the epithelial system besides the CARD9, MALT1 and BCL10, and causes production of antimicrobial peptides which will prevent the yeast form to bind and have the infection progress. Now what happens once the fungus enters inside? Once the fungus enters inside, the neutrophil is a very important cell to control this fungal infection. That's why neutropenia results in invasive fungal infection. Once the fungus is in the body, the neutrophils have to egress out by a process of diapedesis. It will recognize with the help of certain toll-like receptor, C-lectin receptor, phagocytosis, activate the respiratory burst and kill it. So various defects which are over here described, like leukocyte adhesion deficiency, are also prone to fungal infection. So also CGT, as we talked about, being prone to fungal infection. The respiratory burst is extremely important to bring about kill of this fungi. Without the and sometimes you'll be surprised how quickly the activation of respiratory burst kills this fungi, which kills it dramatically. Now, this is a very important cartoon which tells us about the various abnormalities which make you susceptible to chronic mucocutaneous candidiasis. And if you notice, all of them have a defect in IL-17 pathway. Now, there are two types of chronic mucocutaneous candidiasis. One is isolated chronic mucocutaneous candidiasis, which is shown in blue over here, and you have syndromic chronic mucocutaneous candidiasis, which is shown in red over here. The causes of syndromic chronic mucocutaneous candidiasis is a STAT3, which is your Job syndrome defect, then gain of function STAT1, where you are prone to chronic mucocutaneous candidiasis and other fungal infection. Then you have the signature cytokine for Th17 pathway ROR gamma T, and we have another molecule ZNF341, which also presents just like an hyper IgE syndrome, but without the syndromic feature, too much of syndromic features of STAT3. And we have an interesting another syndromic chronic mucocutaneous candidiasis like GNK1, which not only present with chronic mucocutaneous candidiasis, but it also has got it also has got connective tissue disorder. If you see this combination, suspect GNK1. I've already shown you a case of CARD9, which is a devastating, which causes devastating, very slowly invasive fungal infection. And defect in NF-kappa V also causes sometimes ectodermal dysplasia with susceptibility to fungal infection. Now let us look at the isolated chronic mucocutaneous candidiasis. Now this is all to do with Th17 pathway. So IL-17, antibodies against IL-17 which you see in Epstein disease, or a defect in IL-17 receptor A, or an IL-17 RC, or an ACT1 defect, or a defect in IL-12 receptor beta 1, they make you susceptible to getting isolated chronic mucocutaneous candidiasis. So here is just to show you what do you mean by chronic mucocutaneous candidiasis. We mean that you have infection restricted to the skin, the nails, the esophagus, and the genitalia. And this is all superficial. These are not invasive fungal infections, as you can see over here. Well, this is another cartoon which shows you how fungal infection happens and which defect. And we told you in IL-17 you have defective IL-17 mediated antifungal responses. In STAT3 you have impaired AMP production in response to IL-22. You know, STAT3 is so important for production of antimicrobial peptides in the epithelial tissue, which I have already shown you. Now, loss of function mutation of CARD9 can be a very, very devastating thing. There is a defect in innate detection of fungal infection. In STAT3, the Th17 cell development is blocked, and there is a defective antifungal immunity in IL-17 and IL-17F, which we already talked about, because they cannot bind the receptor, they cannot bring about an effect. Now there is one defect which is the commonest cause of gain of function of chronic mucocutaneous candidiasis, that is STAT1 defect, and it is a gain of function defect. That's why it is shown over here in green. So here is a child who came to us with chronic mucocutaneous candidiasis, and he had a history of herpes zoster. This two combination always spells that the patient is likely to have an underlying primary immune deficiency disorder. Well, STAT1, I'll share with you some of the cases which we have seen. We have now more than 12 cases of gain of function STAT1 defect, which we'll talk about. And now this is a patient who at the age of 24 has got a chronic fungal infection right from beginning. And here we notice he's got a bad nail, onychomycosis. You can see what kind of effect of chronic candidiasis has on his tongue and his genitalia. And this is something which we know is a commonest cause, and maybe in future some of this patient can be treated with JAK inhibition because of excess of production of interferon, and they in turn block the Th17 pathway. So it's by using ruxolitinib, which is a JAK2 inhibitor, we may be able to probably prevent fungal infection in patients of gain-of-function STAT1 mutation. So Judy Tubiana has published a large series of 217 patients from 160 and kindred, and this is our first patient of gain-of-function STAT1, worked up by Dr. N. Pule, who is also part of this patient and our contribution to this. Now, this is a boy who was referred to as a CVID. He has an interesting history of oral candidiasis right from childhood. He had this kind of severe candida of the glands, and he had history of diabetes mellitus. He had history of hypoparathyroidism. He had history of edema, and he had multiple autoimmunity. And this he had alopecia areata. He had enamel loss, and this classically is because of IRE gene defect, and this gene defect results in multiple autoimmunity, and the cause of chronic mucocutaneous candida over here is production of antibody to IL-17 cytokine, because of which the IL-17 pathway does not work and make them susceptible to getting chronic mucocutaneous candidiasis. So this is a cartoon which shows you all the various autoimmune and clinical manifestation of AIRE gene defect, and chronic mucocutaneous candidiasis along with autoimmunity is a very important presentation of AIRE gene defect. Now the AIRE gene is very important in expressing endogenous peptide and education of our T cells, so the autoreactive T cells can be culled and removed. If there is a defect in the AIRE gene, there is no expression or poor expression of the antigen, endogenous antigen, and so autoreactive T cells escape and they come into circulation, resulting in multiple autoimmunity. Now we all talked about STAT3. Not only they are prone to candida infection, STAT3 is also important for Th17 pathway, because that is the transcription factor which is important for expression of ROR gamma C in T cell, as we have seen before, and peculiarly STAT3 deficiency makes them prone to, besides chronic mucocutaneous candidiasis, they are susceptible to aspergillosis. But the aspergillosis which they get is in a pre-existing staph cavity. So it's not an invasive aspergillosis, but sometimes you can get an invasive aspergillosis because of STAT3 deficiency, and this is largely because of the Th17 deficiency, which we need to know about. So this is another patient of STAT3 deficiency, hyper IgE syndrome, where they get this kind of large cavitatory lesion, and you can get a cavitatory aspergilloma with chronic mucocutaneous candidiasis in patients of hyper IgE syndrome. Patients of DOCK8 deficiency, they largely have susceptibility to getting fungal infection. But remember, DOCK8 also plays in regulation of STAT3 phosphorylation and translocation to the nucleus. And I think it is because of this defect that they also are prone to getting fungal infections. So I think it is important to appreciate that DOCK8, though they are more prone to getting viral infection like molluscum contagiosum or recurrent herpes zoster infection, but please remember they are prone to also fungal infection because of regulation of STAT3 phosphorylation. So here is an example of a child who had this kind of disseminated molluscum contagiosum infection, and as we talked about that it affects the important STAT3, so the Th17 pathway is affected. IL-12 receptor beta 1 defect is one defect among the 20 MSMD genes with 36 clinical phenotypes, where these patients are prone not only to tuberculosis or atypical mycobacterial infection, but they are also prone to IL-12 receptor beta. They are also prone to getting fungal infection, especially candidiasis. ROR gamma T is another defect where they are also prone to tuberculosis and fungal infection. So if you see a combination of these two, you have to suspect either of this condition. So here is a child, as you can see, has a BCGiosis, and he has a node, supraclavicular node. He also had axillary node. He has got fungal infection of the nail, and you can see his chronic mucocutaneous candidiasis which is having. So this is, when you see something like this, you say, oh, this could be an ROR gamma C, or this could be an IL-12 receptor beta 1 defect, and this patient turned out to be a case of IL-12 receptor beta 1 defect. Interestingly, we had a similar child, and as you can notice over here, he had mild proptosis, and there was a retroviral infiltrate, which on biopsy showed aspergillosis, and he turned out to be an IL-12 receptor beta 1 defect. Here is another patient who presented with PU and he had lymph nodes. And for a workup, his lymph node biopsy showed histoplasma capsulatum, and there was a very interesting history of him having about 6 episodes of salmonella in childhood. And that told us that this could be an IL-12 receptor beta 1 defect. So defective IL-12 or IL-23 signaling impairs the expansion and maintenance of Th17 cells and IL-17 signaling. I think that is the explanation why this patient gets chronic mucopurulous candidiasis. And this is a patient shared by Dr. Harsha Prasad from Mangalore. This patient is an interesting combination of tuberculoma and mucocutaneous candidiasis and onychomycosis. When we were discussing this case, I said this could be an ROR gamma T, and Dr. N. Pugh was very kind enough to do workup for her, and this patient turned out to be our first patient of ROR gamma T. So why does ROR gamma T results in both susceptibility to tuberculosis and susceptibility to fungal infection? The reason you're seeing this cartoon over here, it is ROR gamma T is also important for production of interferon gamma, and ROR gamma T is also important for production of Th17 pathway cytokine, and that is the reason why you have this unusual combination. So friends, if you ever see an unusual combination of atypical mycobacteria or tuberculosis along with fungal infection, you must suspect an ROR gamma T or an IL-12 receptor beta 1 defect. All of you can suspect this molecularly, so you must suspect this. Patients who come to with combined immune deficiency or severe combined immune deficiency, they are pretty prone to getting oral thrush, and they're also prone to getting invasive fungal infection. So here is a child who not only had candida infection, but he's got subcutaneous fungal infection and has got a disseminated BCG-osis. His bone marrow was done and was full of AP, and you can see over here that this combination is not unusual to be seen even in severe combined immune deficiency disorder. Patients of chronic granular disease I have talked to you about, they are particularly prone to aspergillus infection. This child's story we have already gone through, so you have here an unusual fungus at unusual location in the unusual setting. So in the combination spells chronic granular disease. The type of aspergillosis which you see in chronic granular disease is a chronic necrotizing aspergillosis. This patient don't come to with fulminant aspergillus infection. They do have a persistent nagging infection which is very difficult to clear, and they give you a lot of time to make a diagnosis. And it's very important for us to appreciate that aspergillosis behave quite differently in patients of chronic granular disease compared to patients of neutropenia. They also spread by extension. So here is a child who had this kind of a chronic pneumonia going on for almost a year and a half, developing a sinus by involvement of his rib, and there was a rib erosion and formation of sinus. We treated him with 6 months of voriconazole, and you can see there's complete healing of the lesion over here. Interestingly, besides aspergillosis, sometimes we can be very often misled by the imaging. So here is the imaging of a child who was treated for BCG-osis, came back with a relapse, and this lesion was reported as tuberculosis because you can see a lot of necrosis, but we insisted on doing a biopsy. A biopsy was done, and to our surprise, it showed Candida guillermondi. So today at Warrior Children, we have a policy that every child who comes to us, whom we biopsy, we not only send them for histology, but we also send them for culture. And sometimes culture or the organism gives an important clue to suspect an underlying PID. So here is a patient of BCG-osis who had a CD4 lymphopenia and had 3 episodes of histoplasma, one involving the shoulder, one disseminated, and this patient we very strongly suspected an IL-12 receptor beta 1, and Dr. Jean-Laurent Casanova was kind enough to do the workup, and we confirmed that the patient had an IL-12 receptor beta 1 defect. This is a very interesting disorder, GATA2 deficiency or GATA2 haploinsufficiency, and if you look at this cartoon, you will know the protein manifestation with which GATA2 deficiency can come to you. Now, GATA2 deficiency can have various types of infection. They are prone to disseminated NTM infection, non-tuberculous mycobacterial infection. They are prone to severe Clostridium difficile infection. They are prone to genital warts, and they are prone to a lot of fungal infection because they have a impaired dendritic cell and monocytic cell, and the impaired generation of dendritic cell and monocytic cells and polymorph make them increasingly susceptible to viral, fungal, and bacterial infection. So this disorder can come at any age, and it has got such protein manifestation that you need to be extra careful to make a correct diagnosis in this patient. If you start suspecting more often, you'll pick up the diagnosis. There is a very unusual association of chronic mucocutaneous candidiasis with connective tissue disorders in humans, and Dr. N. Puhl, after almost 15 years of work, was able to show that this defect is because of this JNK1 deficiency. This JNK1 is an important molecule in the inflammatory pathway which activates the NF-kappa B pathway, and this is important not only for the Th17 pathway, which explains the chronic mucocutaneous candidiasis, but it is also important for transforming growth factor beta pathway. And because it is important for transforming growth factor beta pathway, it explains the connective tissue type of presentation. So here you can make clinical diagnosis or suspect a molecular defect in many situations. So you have chronic mucocutaneous candidiasis, you can suspect Th17 pathway defect. If you have syndromic features, you can suspect Th17 pathway with syndromic causes of CMC. If you have a patient with a combination of atypical microbacteria and tuberculosis, suspect an IL-12 receptor beta-1 defect and or ROR gamma C defect. If you have an intracellular um, organism like histoplasma capsulatum, we can suspect a defect in IL-12-23. And if you have a combination of CMC plus various autoimmunities, then we can start suspecting possibility of upset. If you have a combination of CMC plus connective tissue disease, we can suspect a JNK1 defect. So you can realize that by just knowing this so well, you can pick up a combination where you can actually suspect an underlying molecular defect. And I think that would make life very interesting. Now here is an example of a fungus where you will always suspect a PID. So this is the patient who at the age of I think 45 came with a PCP infection, confirmed and treated, and when they evaluated him, they found there was a chest mass which was a thymoma. So here a good syndrome. Now good syndrome can cause not only pure red cell aplasia, myasthenia gravis, hypogammaglobulinemia, multiple autoimmunity, but it also can cause a T cell defect, which explains that this patient got pneumocystosis. Now friends, here is just to show you that a lot still needs to be discovered. Here is a patient who had an onychomycosis and had lymphoproliferation, lymphadenopathy, and this is the child who taught us a lot of disorders. It taught us a lot about immunity, and this just tells us that this is a patient whom we could not still find a diagnosis. Those days we were not doing a whole genome sequencing, and time has come when we should start doing a whole genome sequencing for patients where we can't make a definite diagnosis. This is a very interesting boy. He had a pyostomatitis vegetans, and he developed a CNS lesion, as you can see over here in the parieto-occipital region and here in the temporal region. Now this was suspected as tuberculosis. He was treated with AKT for 2 years, but there was progression of lesion, and hence a brain biopsy was done. And to everybody's surprise, the brain biopsy showed that this child had 2 fungi. One was an aspergillosis, and the second was a species similar to mucor. So he had a mucor. Now I've never seen a mucor, which is generally an angioinvasive fungus, to remain in a very chronic presentation, especially in the CNS. And I thought this was very, very unusual. And how I wish we could have worked up this child and found out what his underlying primary immune deficiency disorder. Now, this is a boy who came to us with this kind of fungal infection. He had an almost Obama skew type of smile, and you can see that all of you will agree today that this is a fellow who is in need of workup for an underlying primary immune deficiency disorder. So a lot is yet to be done, and we need to find out more. So in conclusion, Unusual fungus at unusual site with unusual behavior, with unusual bug, with unusual association, with unusual pattern, with unusual response always spells PID, or primary immune deficiency disorders. Primary immune deficiency disorders must also be recognized among usual fungal infection by their unusual persistence, recurrence, and association. The example is a candida which is persistent, recurrent, then you have to look for underlying PID. Th17 pathway defect makes you prone to chronic mucocutaneous candidiasis, which could be syndromic or isolated. Invasive aspergillosis is much more common among patients of chronic granulomatous disease patients in India and is a characteristic chronic necrotizing pattern of involvement. Fungal isolate or identification of fungal infection should make one lead for a search for PID. Further etiologies can be looked for to identify monogenic susceptibility to fungal infection. I think this is very important for all of us to appreciate that a lot needs to be discovered, and once you are aware of this condition, you will probably try to find out more about this. So I think I would end at this, and thank you very much for going through this video which we have uploaded, and I hope that it will give you some concept. I've tried to repeat this thing. It may be a little longer, but please go through it gradually so that you can learn about newer aspects about primary immune deficiency disorder. A lot needs to be done, and I think we need to join hand, collaborate, so we can do a lot of this thing together. Well, thank you very much for giving us a very, very, uh, you know, in, for going through.